Welcome to today's episode of Myeloma Crowd Radio, a show that connects patients with myeloma researchers. I'm your host, Jenny Ahlstrom, and we'd like to thank our episode sponsor, Takeda Oncology, for their support of the Myeloma Crowd Radio program. Now, before we get started with today's show, I'd like to mention just an upcoming event we have later today. We'll be hosting a webinar about using BlendRep in the clinic. It will be an hour-long discussion with Dr. Joshua Richter from Mount Sinai at 4 p.m. Eastern Time. So you can find that on myelomacrowd.org/events. And also a reminder, we are running a genetic study inside of HealthTree to learn which treatments are showing the best results for different segments of genetics in patients in the real world. So to join that study, you can go to healthtree.org and request that we help complete your profile for you. We have over 500 patients participating so far in that study, and breaking patients down into subgroups requires a significant number of patients to be really meaningful. So there's sufficient data for each subtype, like 414 patients or deletion 17 patients or 1114 patients or the like. So you can find that on healthtree.org. And now on to today's show. So AL amyloidosis is a condition that can occur in conjunction with multiple myeloma, and it's typically harder to diagnose, and patients with amyloidosis need careful care. So with us today is myeloma and amyloidosis expert, Dr. Sascha Tuchman, and I've had the pleasure to meet Dr. Tuchman last week in person as we performed HealthTree University video interviews. He explained amyloidosis beautifully, and I invited him to participate on this show. So, Dr. Tuchman, welcome to the show. We're so pleased to have you with us.
Good morning. Thanks for having me.
Now, before we get started, let me just do a short introduction for you. Dr. Tuchman is Clinical Associate Professor and Director of the Multiple Myeloma and Amyloidosis Program. He's also Associate Chief for Outpatient Clinics and Outreach in the Division of Hematology at the Lineberger Comprehensive Cancer Center at the University of North Carolina at Chapel Hill in the Raleigh area. He's a regular speaker for continuing education on myeloma and amyloidosis topics and has received significant funding for his academic myeloma and amyloidosis translational research. He has been an author for books and chapters on both topics. He has received many awards, including the Duke University Eugene Stead Teaching Attending Physician Award, the Burroughs Wellcome Foundation Travel Award, the ASH Travel Award, and the American Society and ASCO Merit Award. I was so impressed by the number of scholarships that you got at Georgetown, and your summa cum laude honors, but over 9 scholarships. So I thought that was very amazing. And I know you've done a lot in also geriatric work in multiple myeloma, so we're just excited to talk to you about multiple topics today.
Thanks for the extremely kind introduction.
Well, Dr. Tuchman, let's get started with just some basics. So what is AL amyloidosis, and then how does that differ from other types of amyloidosis?
So AL amyloidosis is a protein problem. So we all, of course, have proteins in our body. They're a natural part of skin, muscle, many other parts of the body. And amyloidosis of any form is a problem involving different types of proteins. So there's multiple different types of amyloidosis, and it comes from, or it really stems from what type of protein the amyloidosis is made from. But basically, in amyloidosis in general, what happens is that you have an abnormal protein that deposits in different tissues. It can be the heart, can be the kidneys, can be nerves, can be many different parts of the body. And as that abnormal protein deposits in the different tissues, then they have trouble functioning. So that protein interferes with normal organ function. And so when we do a specific test on biopsies, you can see that protein under the microscope, and we refer to that as amyloid protein, or the condition is amyloidosis. And so again, amyloidosis, or that protein, can come from different places. That's really one of the very interesting parts of this condition. And the one that's most relevant to multiple myeloma and how I got into this is this form of amyloidosis called AL, or light chain amyloidosis. All the different types of amyloid have different subtypes, and they all start with this abbreviation system that starts with the letter A, and then there's some letters after. And so AL stands for amyloid light chain. And so in light chain amyloidosis, or AL amyloidosis, what happens is that you have abnormal cells in the bone marrow which come from the immune system called plasma cells. Those are incidentally the same cells that are sick in the multiple myeloma condition. But when people have amyloidosis, then those sick plasma cells in the bone marrow make abnormal protein, which circulates in the blood, which is most often this protein called light chain, which again, a familiar term for anyone who has multiple myeloma. And then again, when people have this amyloidosis condition, then that light chain protein sticks in the different organs and forms that amyloid, which again sort of gunks up the machinery of those different organs. And so it most commonly involves the heart and the kidneys, but also commonly involves the GI tract, nerves, can involve the lungs, can involve skin, many different organs. And so again, that's light chain amyloidosis, where the problem starts in the bone marrow with the plasma cells, light chain proteins circulating in the blood, and then that light chain protein deposits in the different organs and causes them not to work quite right. And so in terms of how that's different from other types of amyloidosis, that's again one of the very interesting parts of this condition, and that there's other forms of amyloid which come from completely different processes that have nothing to do with plasma cells, nothing to do with light chains, nothing to do with the bone marrow. But what happens in those other types of amyloidosis is that abnormal protein comes from somewhere else, some other disease process in the body. That different protein deposits in some of those same tissues and then still forms that amyloid protein. So the most common form, for example, in the United States is called TTR, or transthyretin amyloidosis. The abbreviation for that one is ATTR amyloidosis, unlike AL, which we talked about a couple minutes ago. And so in TTR amyloidosis, that's actually a protein that comes from the liver. The liver synthesizes this protein called TTR. Sometimes it makes normal TTR. Sometimes it makes a slightly abnormal form of TTR protein, and that protein deposits primarily in the heart or the nerves and causes those organs not to work right. And when we do the testing for it and the biopsies and the staining, we still see that amyloid protein, but as you can discern, it's coming from a completely different place from what we see in light chain amyloidosis. And it's really important to sort that out because it of course, heavily influences how we manage and treat the condition.
Right. What's the root cause of the amyloidosis? So you can attack it properly. Right. So how many people are diagnosed with AL amyloidosis every year? And then can you just describe the relevance or the association it has with myeloma? Like what percentage of myeloma patients might have this? And do you find it in some of the earlier precursor conditions?
Sure, great question. So in terms of how many patients are diagnosed with light chain amyloidosis every year, it's probably about 3,000 patients are diagnosed with amyloidosis every year. So when I think about this in clinic, I think about it in terms of being about 1/10 as common as multiple myeloma. So multiple myeloma is diagnosed in about 30,000 people per year in the United States, a little bit more than that, and then light chain amyloidosis is closer to 3,000. And these conditions we often talk about them in conjunction with one another because these conditions are related. I think of them as sort of cousins in the same family. They're different, but they're related. And the reason for that is that in both light chain amyloidosis and multiple myeloma, the problem boils down to those plasma cells in the bone marrow. Again, sick plasma cells in the bone marrow that are growing there and sometimes causing trouble. Those sick plasma cells make those abnormal proteins that float around in the blood. Sometimes it's M spike, sometimes it's light chain. But the behavior of the cells and or the protein in the body can be quite different. In some people, the problem is multiple myeloma, where the damage that the cells and protein cause in the body fit the specific patterns that we see in multiple myeloma, like bone spots and anemia, and high blood calcium levels, in contrast to amyloidosis, where in those people that abnormal protein in the blood sticks in the different organs and forms amyloid, which can be quite different: congestive heart failure, chronic diarrhea, nerve trouble, which again is very different from multiple myeloma. And so these two things really exist on a spectrum in the sense that they're both plasma cell disorders. They both stem from those abnormal plasma cells in the bone marrow. But again, how they affect different people can be quite different. So in terms of how many patients with multiple myeloma develop amyloidosis, that number hasn't exactly been mapped out as the question is specifically phrased, but what we do know is that about 10 to 15, maybe 20% of patients with multiple myeloma have amyloidosis with it. So people can have multiple myeloma by itself, which is most common. People can have amyloidosis by itself, which is less common, but still still certainly we see it, and then some patients have sort of an overlap, meaning that they have a plasma cell disorder with some features of multiple myeloma plus some features of amyloidosis. But in general, if you look at the textbook, it's about 10 to 15 or 20% of patients with multiple myeloma that have amyloidosis also.
Yeah, that was going to be my question. Like, I knew you could have myeloma without having amyloidosis, but I didn't know you could have just amyloidosis without having any myeloma involvement. That's interesting.
You can, and that's really one of the fascinating. Yeah, I mean, you're exactly right. That's one of the really fascinating aspects of these conditions, in the sense that it really, again, all boils down to sick plasma cells in the bone marrow and abnormal proteins in the blood. But how these two sort of parts of the same condition affect an individual patient is completely different. And a lot of that derives from how those plasma cells are behaving in the bone marrow, and then probably also the structure of that abnormal protein that's in the blood. In terms of behavior, so we know that there are many patients that have some of those abnormal plasma cells in the bone marrow, and they may be in the bone marrow and growing abnormally but not causing trouble, like the things that we see in multiple myeloma. The blood calcium level is normal, they're not anemic, they don't have kidney failure, other things along those lines. And that's really driven by, again, the behavior of those cells. In some patients, they cause those problems, and some patients, they don't. And similarly, for that protein, some patients have an abnormal protein that's in the blood that comes from those plasma cells, and it's perfectly structured so that that protein can stick in the different organs and form that amyloid. And that's a certain number of people. But then there are other people that whose myeloma or whose plasma cells make an abnormal protein that really can't form that protein, no matter how much of it is in the blood. And so we see this clinically in the sense that sometimes we have patients with multiple myeloma who have extremely high levels of these abnormal proteins in the blood, be that M spike or be that light chains, and they don't form amyloid protein. And then other times, and this is pretty common in amyloidosis actually, that we can have patients who very clearly have clinical manifestations of light chain amyloidosis. They have severe heart failure, they have severe kidney injury, and yet the levels of those proteins in the blood are quite low. And that just tells you that it's really driven by the structure. Depending on the structure, it either can or cannot form amyloid. And so yeah, again, back to your question, it's really one of the fascinating aspects of these conditions, in the sense that it's all about plasma cells, it's all about those abnormal proteins in the blood. And so when you do the blood test, you do the bone marrow biopsies, it looks quite the same. But then when you walk into a room and see someone in clinic, what a patient looks like and what problems they can have related to this can be completely different.
That's so fascinating. And when someone's diagnosed, when you have that 10 to 15% of myeloma patients that have amyloidosis, does it show up like as they're presenting with myeloma? Does it show up later? If you're a myeloma patient, do you have to kind of watch for it, for something that could occur later that didn't occur at your initial diagnosis?
So it can. So most often when we diagnose the people who have multiple myeloma with concurrent amyloidosis, or basically they have sort of the overlap of both conditions, most often we pick that up at diagnosis, meaning someone comes in with myeloma and we figure out that they have amyloidosis also, or vice versa. They have amyloidosis and then we figure out that they have multiple myeloma too. That's most common, but sometimes patients do develop something else along that spectrum later on in the disease, meaning someone has multiple myeloma. In the beginning, it was pure multiple myeloma, no amyloidosis. They've had it for a few years. It's come back a couple times. And then later on in the disorder, they develop amyloidosis. And conversely, someone can have amyloidosis and then later on in the disorder develop multiple myeloma. And that probably has to do with the evolution of those cells over time, of the protein over time, and things along those lines. So yes, it can evolve from one into the other over time.
And can smoldering myeloma patients have amyloidosis?
They can, and it's a little bit controversial in the sense that, so from a fundamental perspective, yes, they can, in the sense that any plasma cell disorder in which there are plasma cells in the marrow and then the abnormal proteins in the blood can form amyloidosis. But what to call smoldering myeloma when somebody has amyloidosis is a little bit tricky, and this is more semantics. But what I mean by that is that by definition, smoldering myeloma is asymptomatic, meaning a patient can't not only not feel it, but they also can't have the other manifestations of, let's say, multiple myeloma, like high blood calcium, kidney problems, anemia, bone lesions, the classic CRAB criteria that we refer to in the medical textbook. But similarly, they also really shouldn't have amyloidosis. They shouldn't have other manifestations of the disease that demonstrate that the cells and/or protein are causing injury. And so, it's sort of a terminology issue. For what it's worth, when I have patients, if they have light chain amyloidosis, I don't refer to smoldering myeloma, but some myeloma and amyloid experts do, and more to just as a statement of basically how many of those abnormal plasma cells were in the bone marrow, in the sense that classic amyloidosis often has a relatively low number of plasma cells in the bone marrow, but sometimes patients have more, and that's sometimes referred to as light chain amyloidosis with smoldering myeloma. So more of a terminology issue, but from a fundamental sort of basic perspective, yes, that can happen for sure.
Yeah, I know some of the myeloma experts want to sort of get rid of that whole smoldering myeloma designation anyway. Like, you either have MGUS or you have active myeloma, but maybe there's not something in between. I don't know. That's sort of controversial right now, I know.
Yeah, it's hard. I mean, there really is a spectrum to a lot of this. And then when I have trainees in clinic, I often tell them that this is quite different from something like lung cancer, for example, where if a patient has a lung nodule and you do surgery and you take it out, it's either cancer or it's not. There's no gray zone, really. But in these plasma cell disorders, be that MGUS, smoldering myeloma, light chain amyloidosis, multiple myeloma, there really is a spectrum to this. And so I think a lot of the benefits that patients have from seeing experts is that we do this a lot. We fully understand the spectrum, as opposed to sometimes people who don't see a lot of these disorders and they don't fully understand the spectrum and how these things are sometimes nuanced, and it's not always completely clean.
Well, that leads us to signs, symptoms, and diagnosis. So on the myeloma side, we are always advocates for getting a myeloma specialist on your team, just because myeloma care is so nuanced. And from what I've heard about amyloidosis, it's like even more so. Like, the symptoms might be a little harder to pick up, or the diagnosis might be a little harder to make if you don't know what you're looking for or whatnot. Do you want to just describe how it's properly diagnosed, and then is it hard to diagnose?
Sure. So yes, it can be hard to diagnose, and so amyloidosis, you're exactly right, can be tricky in the sense that it's sneaky. It's sometimes tough to pick up, and one thing is that it really can affect different organ systems, and so it's hard to give a specific checklist of watch out for these three things, and as long as you don't have these, we're good. And a lot of that has to do with the fact that amyloidosis really can affect almost any organ in the body. It most commonly involves the heart and the kidneys, but it also can involve the GI tract. It can affect the nerves, so the ones that go to the hands and feet that give sensation, and so this thing called peripheral neuropathies with damage to those nerves. It can affect the lungs. It can affect the skin. It can involve lymph nodes. It can go to multiple different places. And so, again, giving a checklist of specific things to watch out for is somewhat challenging. But I would say that there are certain things that more for the clinicians as opposed to the patients that clinicians should watch out for. Of course, good always for patients to be vigilant, but a lot of this is just the clinicians need to recognize red flags with someone who, quote unquote, just has multiple myeloma, to recognize that they may also have the amyloidosis condition. And so some of those things that we think about again, fit with the organs that amyloidosis most typically involves, and that's the heart. And so somebody with new onset congestive heart failure, especially what we refer to as heart failure with preserved ejection fraction, which is a specific type of heart failure, that can be a red flag for amyloidosis. Someone with bad peripheral neuropathy, so again, numbness and tingling in the hands and feet. Another one is somebody with new onset significant GI symptoms, so it can be nausea, diarrhea, constipation, just changes in sort of normal bowel function. Low blood pressure, so that's another common one that happens in amyloidosis. Amyloid loves messing with the nerves in the body that regulate blood pressure. So if somebody, for example, previously had high blood pressure and all of a sudden they've been able to come off their blood pressure medications, and in fact their blood pressure is kind of low despite the fact that they're no longer taking blood pressure medications, that's another red flag for amyloidosis. And then there are two things that I'll mention which are really classic symptoms. They occur in a minority of patients, but they're really classic symptoms that really should tip off the clinicians to the fact that we need to think about amyloidosis. And one is called macroglossia. And so that just refers to enlargement of the tongue. And what happens with that is that same amyloid protein that can deposit in other organs of the body deposits in the tongue. It can make the tongue thick. It can interfere with speech. Speech can become somewhat slurred. and even can interfere with swallowing in people who have it to a severe enough extent. That's one, and then the other is basically bruising around the eyes. So sometimes when amyloidosis gets into the skin, it makes the skin thinner and more delicate and fragile. And so the skin around the eyes is, of course, fairly thin and fragile already, and so when you add some of that amyloid, sometimes people have very easy bruising. And so there's this phenomenon called raccoon eyes, if you look in the medical textbook, which is basically bruising around the eyes that looks almost kind of raccoonish. And that's another red flag for amyloidosis. And so the big things, and when we do education with, for example, neurologists and cardiologists and nephrologists, we really go through these sorts of symptoms and say that if you have patients with unexplained, let's say, heart failure or unexplained kidney problems that could fit with amyloidosis, things like that, then we say we really need to think about the amyloidosis condition and do the testing to look for it. And then similarly, especially for the hematologist oncologist who may be listening in, when we see patients with when we see patients with a new diagnosis of multiple myeloma, but they have some of these other symptoms, which really do not typically come with multiple myeloma, but that are classic for amyloidosis, then we have to think about amyloidosis also, and do the appropriate workup to figure out whether or not a patient has that.
Mm-hmm. And some of these things, I mean, having a bigger tongue or bruising around your eyes, that's probably pretty obvious to a patient if that's happening. So patients should probably speak up and say something too.
Exactly.
And then the neuropathy could be confusing, right? Because myeloma itself can create neuropathy.
It sure can. Yeah, this is sometimes very tricky in that this is more often neuropathy from time of diagnosis, meaning that's somebody who has not been on myeloma therapy before, new diagnosis of multiple myeloma, they don't have diabetes or other things that commonly cause peripheral neuropathy. If people like that come in with really numb feet, numb fingers, and then especially some of the blood pressure issues that I mentioned, that's another red flag for the amyloidosis condition. So again, something to think about.
Okay, so definitely things for patients to watch out for as well. So how do you treat AL amyloidosis, either by itself or, I mean, you mentioned earlier that there are like 3,000 patients diagnosed with AL amyloidosis per year, and then that seems to be, there's like 10 to 15% of myeloma patients who have that, so maybe that's the bulk of that is patients that also have myeloma. But how do you treat if they have myeloma, and then how does that differ from if they don't have myeloma?
Yeah, so treating amyloidosis or light chain, just to be clear, light chain amyloidosis, not the other types, but treating light chain amyloidosis is similar but different to treating multiple myeloma. And this kind of makes sense. It's similar because, again, it all boils down to those sick plasma cells. And when we think about the drugs that we have available for treating multiple myeloma and amyloidosis in general these days, these drugs are almost entirely focused on killing plasma cells. So lots and lots of different drug classes, as I know you've discussed with your audience on other shows. But all these different drugs, they're all just different ways of attacking those bad plasma cells in the bone marrow. And so in multiple myeloma, you kill off those cells, the cells cause less trouble, the protein levels come down, and the trouble in the body that the multiple myeloma was causing clears up and hopefully goes away. And in amyloidosis, it's a similar concept, but a little bit different in the sense that in pure amyloidosis, in the absence of multiple myeloma, the cells in the bone marrow usually are not doing much in the sense that they're usually not causing much trouble. There may be a few cells there. They're growing in a way that they're really not supposed to, but they're not causing a lot of the trouble that we see in multiple myeloma, such as the high blood calcium levels that occur when those myeloma cells are chewing on the bone. They're not causing severe low blood counts because the myeloma cells are taking over the bone marrow. In amyloidosis, those cells are often fairly benign. But as we know, what happens is that those fairly benign cells secrete that abnormal light chain protein, which deposits in the different tissues and forms the amyloidosis. And that's really where the problem comes in. It's when those organs aren't working right that's what patients feel and what can even become life-threatening in amyloidosis. And so again, back to your question of how we treat these, it's the same principle in amyloidosis in the sense that we often use and in fact borrow a whole lot of drugs that we use to treat multiple myeloma. And we use these in amyloidosis in the same way, in that we use these different medications to kill off as many of those bad plasma cells as possible. Hopefully those plasma cells, just because there are fewer of them around, they then secrete less of that abnormal light chain protein that's in the blood. And as that protein comes down, there's then less of it around to attack the different organs, like the heart, like the kidneys, like the nerves, like all the different organs that amyloid likes to mess with. And as we sort of shut down that attack by those abnormal proteins, then those different organs, the function hopefully stabilizes, or in many cases, the function can actually get better. The kidneys can heal, the heart can heal, the nerves can get better, the different organs can heal up. And again, it's because those organs are no longer under attack by those bad proteins. And so again, treating amyloidosis is very similar to treating multiple myeloma, and that it's a lot of the same medications. But one critical thing to realize, and this is both for patients and for clinicians, is that it's similar, but it's not the same as treating multiple myeloma, in the sense that it's easy to look at multiple myeloma treatment regimens and just say, okay, we'll give this in amyloidosis. But the key is that lots of regimens that are often very tolerable and effective in multiple myeloma are not necessarily tolerable in amyloidosis because of the different ways in which amyloidosis affects the body. And so one common thing, if we think about, for example, first-line treatment of multiple myeloma these days for a lot of patients is the so-called RVD regimen. So R, of course, is Revlimid, that's lenalidomide, V is Velcade, bortezomib, and then D is, of course, the dexamethasone. And so when we think about that regimen, it's generally highly effective and also very tolerable for many patients with multiple myeloma. Not everyone, but that's a standard regimen because it works and it's tolerable and it's a good one. But when we try that regimen as it's published in patients with amyloidosis, it often is not tolerable. And so as examples, when we think about the dexamethasone that we give with the RVD myeloma regimen, so it's typically, if you give it according to the way it's initially published, then it's 20 milligrams 4 times a week. So 20 milligrams on day 1, 2, 4, 5. So pretty good dose of dexamethasone. And when patients with amyloidosis already have heart failure and what's called nephrotic syndrome, which is a kidney problem that leads to a lot of swelling, those patients already have a lot of trouble with fluid retention that we don't see much in multiple myeloma. It can happen, but it's usually not a major problem. But when you give somebody with amyloidosis that essentially 80 milligrams a week of dexamethasone with all the combined doses, then it can lead to severe problems with fluid retention and even congestive heart failure up to the point that it can lead to hospitalizations. And so dexamethasone specifically is a drug that's generally, it's problematic in multiple myeloma too, but when used at myeloma doses in amyloidosis, we can really hurt people. And then similarly, if we look at Velcade or bortezomib, again, a very common drug that we use in multiple myeloma, we know very well from multiple myeloma that bortezomib or Velcade does cause peripheral neuropathies, the numbness and tingling in the fingers and toes, and can cause low blood pressure, but generally not a major problem as long as it's watched closely and doses are adjusted if those problems start to come up. But you can imagine that for a patient with amyloidosis who may already have significant peripheral neuropathy coming in, meaning they can't feel their hands and feet, and on top of that, if they come in and their blood pressure is already very low to begin with because that amyloidosis has messed with the nerves that regulate blood pressure, then you give them some bortezomib or Velcade on top of that, and they have much less threshold to tolerate or much less reserve to tolerate the low blood pressures that drug can cause. So again, when given at standard multiple myeloma doses, the Velcade bortezomib drug can also be problematic in amyloidosis. And so this just brings me back to your initial question of, they're similar in the sense that we use a lot of the same drugs to treat multiple myeloma and amyloidosis, but it's not as simple as just saying, okay, whatever works in myeloma works in amyloid, just do the same thing. It really helps. That's why it's important to see people who do amyloidosis, because we can make those adjustments and do the translation, so to speak, appropriately, so that we can get the benefit of those drugs from multiple myeloma, but not hurt people in unexpected ways by just, again, doing the same thing that we always do in multiple myeloma. There's a little bit of finesse and art to it, I think.
Yeah, I was going to ask you too about even the Revlimid or replacing the Velcade with Kyprolis, because the Revlimid you might have kidney issues, right? On Revlimid, do you see that or no? And then Kyprolis, if you're swapping out Kyprolis for Velcade because of the neuropathy, are you impacting the heart in any way?
So Revlimid or lenalidomide, that drug is of course affected by kidney function in the sense that it's excreted or cleared out of the body by the kidneys. And so in any condition, multiple myeloma, amyloidosis, any other condition in which we're using that drug, if kidney function is impaired, then we have to reduce the dose. But even beyond that, in amyloidosis, lenalidomide or Revlimid is tougher to tolerate for reasons that aren't totally clear and that don't totally stem from kidney function. And this has been shown in studies done by Boston University, which is one of the big amyloidosis centers, where they did studies even 15 years ago, initially looking at lenalidomide or Revlimid in amyloidosis, and pretty quickly found that the standard 25 milligrams dose that we use in multiple myeloma is generally not tolerable in amyloidosis. So if I remember correctly, when they did the study, the first 8 patients on this study got 25 milligrams of lenalidomide or Revlimid, and all of them needed a dose reduction pretty quickly, which is very unusual for multiple myeloma. We just don't see that. But that just goes to show you that patients with amyloidosis really had trouble tolerating that quote-unquote normal myeloma dose. And then even you mentioned Kyprolis or carfilzomib, a great drug in general for treating multiple myeloma, and can be helpful in amyloidosis, especially for patients that do have significant peripheral neuropathy or low blood pressure to begin with. But again, so one thing that we see in amyloidosis pretty commonly is can be significant heart failure, and so of course Kyprolis or carfilzomib is associated with heart failure in multiple myeloma. And so that's, again, one that can be helpful in amyloidosis, but can be tricky in a patient who already has heart trouble, and because of that, carfilzomib or Kyprolis has had somewhat limited success in amyloidosis so far. But it does have a role for certain patients for sure.
And so, this is very nuanced in my opinion, and even for myeloma experts, do all myeloma experts treat amyloidosis? Or, because I know there are a few of you throughout the country that do specialize in amyloidosis as well. And do you suggest that amyloidosis patients kind of go to those specific centers where there is expertise? Or if you're with a myeloma specialist, do you consider them knowledgeable enough to do the care?
So what I'd say is that anyone who does light chain amyloidosis, I'd say anyone who specializes in light chain amyloidosis almost always does multiple myeloma also. So it's very difficult to be just an amyloidosis physician, largely because there's so much overlap and because multiple myeloma is much more common, but the converse is not necessarily true, meaning that among multiple myeloma physicians, some do amyloidosis also and, find it interesting, enjoy it, and have clinical expertise in it, but there's a decent number of multiple myeloma experts who do not do amyloidosis. And so it is important for somebody with multiple myeloma who also has amyloidosis as a significant part of their problem to ask their myeloma expert if they regularly do amyloidosis also. So seeing a myeloma physician does not necessarily mean that you're seeing an amyloidosis expert.
Yeah, okay, that's good to know. And we will include that in our directory as well. So we have that in some of the descriptions so patients can, and I'll do a better job of noting that on the directory, because that's important for people to be able to find a specialist. So you talked about,
right.
when you're talking about RVD or KRD or something like that as a standard induction therapy, and you kind of went through reasons why some of all of that might be a problem, then what do you do? Do you do amyloidosis patients do transplant, or do you use monoclonal antibodies up front then instead, or what's the standard of care right now for AL amyloidosis patients?
So finally, happy to report that it's finally evolving, and that for decades now, everything in amyloidosis has basically been borrowed from multiple myeloma, and that drugs, of course, get approved in multiple myeloma, and then smaller studies are done in amyloidosis, but the larger studies have never been big enough in amyloidosis to actually result in approval, which meant that we were always borrowing drugs again from multiple myeloma. But that finally changed this year, and I should say last year, and then approval came this year based on this study called Andromeda, like the Andromeda Galaxy, where this was a study looking at patients with newly diagnosed light chain amyloidosis, not myeloma, just light chain amyloidosis. And it was a study in which patients got a standard regimen called Cybor-D, which I'm sure your audience is familiar with, but that's cyclophosphamide, bortezomib, which is Velcade, and dexamethasone. And then all patients on the study got that regimen, and then patients were also randomized to also have the drug daratumumab or Darzalex added to the regimen. So half of patients got the daratumumab, half of patients did not. And the daratumumab improved outcomes in patients who got it, and so that combination has been approved by the FDA and the European Medical Association for treatment of light chain amyloidosis here in the United States and in Europe. And so that arguably is the standard of care for newly diagnosed light chain amyloidosis these days. Again, there's always a little bit of nuance to it, but that's arguably the standard of care currently. With close attention paid to things like bortezomib or Velcade dosing, dexamethasone dosing, and that it's not using the same doses that we use in multiple myeloma is not always the way to go. So that's probably the regimen. We just have to be careful with it.
Mm-hmm. So you can take it. It's just that your doctor has to watch you closely, and you might be dose adjusting, like you're saying.
That's right.
Yeah. Okay, so when we talk about myeloma, I know there are different kinds genetically of multiple myeloma. Do you see the same thing in amyloidosis? Do you, or how does that work? Or do you just go with the, potentially genetic features? Like if a patient has 1114 or something like that, would you use in their myeloma and then they have amyloidosis too, would you use a venetoclax or something like that for them?
Yeah, so we do that. We can see a lot of the same genetic abnormalities in amyloidosis that we see in multiple myeloma. The prognostic and therapeutic significance of those abnormalities has not been nearly as well mapped out in amyloidosis as it is in multiple myeloma. Although I'd say that even in multiple myeloma, we have a ways to go to figure out what to do with those different genetic abnormalities. But the one that's been clearly reported with the greatest significance in amyloidosis is the one that you mentioned of the T1114. So that phenomenon in which, all the chromosomes, of course, have numbers 1 through 23, and then 1114 that we refer to just means that a piece of chromosome 11 and a piece of chromosome 14 got switched. And so when patients have that, we refer to it as T1114, and that's a relatively common finding in multiple myeloma, and we see it even more in amyloidosis. But as you mentioned, that's a drug that often predicts response to the drug venetoclax, which does things in the cell that's particularly effective in patients who have that T1114 abnormality. So there's a lot of interest in using that drug in amyloidosis currently. Studies are ongoing. We do use it in some patients. It's hard to say that it's a standard of care just because there's not a whole lot of data for it yet. But we certainly do think about it for patients with that T1114 translocation in amyloidosis, typically after they've been through other therapies. We wouldn't use that front line, but often later on.
Mm-hmm. And it hasn't been FDA approved yet in myeloma yet, but I know they're working on that.
Right.
Mm-hmm. But I do know some patients who have been able to, kind of get early use of it when other things are not working.
Yeah, we can generally get it. And amyloidosis is sometimes a little bit trickier just because there's not as much literature to support it. But as you know, in multiple myeloma, not FDA approved, it's compendium listed, meaning that some authorities say that we should be using it. And in general, it's a matter of insurance approval, but we usually can get it in appropriate patients with multiple myeloma.
And is stem cell transplant used in amyloidosis or light chain amyloidosis patients?
It is. The stem cell transplant is used in light chain amyloidosis. Again, much like what I said about other things as relates to multiple myeloma, it's used, but it's a little bit more nuanced, and a lot of that has to do with the fact that transplant is inherently somewhat riskier in amyloidosis than it is in multiple myeloma. And a lot of that has to do with the heart issues that we commonly see in amyloidosis that we don't see in multiple myeloma. And so, we saw this 15, 20 years ago when the first larger studies were coming out in amyloidosis, in the sense that, so when these studies were done, they saw a much higher death rate with stem cell transplant in patients with amyloidosis compared to, what we would typically see for multiple myeloma, for example. And so what I mean by that is that in multiple myeloma, in most centers, when we talk about anticipated mortality rate or rate at which people die during the transplant, it's typically 1, 2, maybe 3%. So it's a real number, but it's a relatively small number. But early amyloidosis studies looking at stem cell transplant mortality rate was up to 25 or 30%. So 1 out of 4, 1 out of 3 patients, which is just way too high, especially for a therapeutic modality that's not curative. It's not like that it was worth the risk because it cured a lot of people. And then what we figured out is that was largely driven by heart trouble. So amyloidosis, we know, commonly causes heart trouble. And when patients had significant cardiac or heart involvement by amyloidosis, then when we tried to do stem cell transplant, there was a much higher risk of low blood pressures, other complications, arrhythmias or abnormal heart rhythms, kind of short circuits of the heart, and many people didn't survive. And so what's happened since then is that we figured out how to appropriately risk stratify patients with amyloidosis for stem cell transplant, basically how to pick the candidates that are likely to do well with it. And so we do it, but again, it's a little bit more nuanced than it is in multiple myeloma.
Oh, that's fascinating. I did not know that. Okay, that's so interesting. And then let's talk about new approaches, because as you're very aware, because you're involved in all the research, immunotherapies like the bispecific antibodies and the antibody drug conjugates and CAR T therapy are being tested. Have amyloidosis patients been able to? Are there studies that are using these therapies? And then what are you seeing, if so?
So I have not seen any studies involving that yet. So given the fact that amyloidosis is often tricky to treat due to the heart trouble and some of the other trouble that those patients experience, and the fact that it's a rarer disorder, there's often a lot of hesitancy to use the new therapies in amyloidosis. And so what often happens is that things, as we've seen historically even until now, drugs get developed in multiple myeloma, we get comfortable with using them, and then trials start up in amyloidosis also. And so this is where I'd say a lot of the current immunotherapies are in amyloidosis. Some of the early trials are starting now, but there's not a whole lot of data yet to say how useful those therapies are in patients with amyloidosis. And so things like CAR T, it makes a lot of sense that if CAR T works in multiple myeloma, it should work in amyloidosis also, but amyloidosis patients, again, probably have a higher risk of some of the cardiac and other complications that we can see from CAR T. And so understandably, with a relatively new technique, there's a lot of hesitancy to do that. And so those things are coming, but really not a whole lot of data to speak of yet.
And so what are the most, well, I guess my question is, if a patient has multiple myeloma and they also have AL amyloidosis, can they join clinical trials, or is that like a exclusion criteria for many of the trials?
Yeah, so this is a really unfortunate gap in clinical research, because the long story short is that generally, no, they can't get on clinical studies unless we really prove that the amyloidosis is clinically insignificant. Meaning, and the way that happens is that sometimes patients have a bone marrow biopsy. The pathologist stains it for amyloidosis using this test called Congo Red. They see the amyloid there, but the patient, him or herself, clearly has no, heart trouble, kidney trouble, anything else to suggest that this is real amyloidosis. So it's almost an incidental finding. But other than that, typically patients with kind of quote-unquote real multiple myeloma can't go on trials for amyloidosis, and conversely, patients with real amyloidosis can't go on trials for multiple myeloma. And that's just the way the trial eligibility criteria are typically written, in the sense of the way that multiple myeloma trials typically say patients with amyloidosis are excluded, and then amyloidosis studies typically say that patients with multiple myeloma are excluded. And a lot of that just has to do with the fact that even though they all boil down to abnormal plasma cells and abnormal proteins in the blood, clinically, these patient populations can be quite different. And so you can imagine that when we do these clinical studies, if we have a really heterogeneous or variable group of patients going on, it can really make the trials tricky. And as I mentioned before, drug dosing is often different in amyloidosis as opposed to what we use in multiple myeloma, which, on clinical studies, dosing is typically standardized. And so you can imagine that picking a dose that would be appropriate for somebody with amyloidosis may not be the same as picking that dose for somebody with multiple myeloma. So it's unfortunately a little bit of a tricky situation, but often patients who have both conditions would be excluded from clinical studies.
Yeah, that's tricky. Very hard with the way the studies are designed, probably.
Right.
Well,
That's right.
Do you want to share open amyloidosis clinical trials? I know you do a lot of academic research on the myeloma side, and
sure.
I'm sure.
Yep. So I think that two things that I'd mentioned, which I think are extremely exciting in amyloidosis. One of them is basically new drugs that are coming, which will hopefully help to break down amyloidosis that's in tissues already. And this is completely separate from multiple myeloma. It's nice because amyloidosis kind of finally has its own thing. It's not just borrowing everything from multiple myeloma. And what I mean by that is that, again, when people have light chain amyloidosis, we said cells in the bone marrow, light chain protein in the blood, light chain protein deposits in the different tissues. When we think about all the medications that are currently FDA approved for treating light chain amyloidosis, they're all geared at killing off those bad plasma cells, which we said earlier reduces the level of that abnormal light chain in the blood, and then that results in less of that light chain protein being available to beat up on the different organs in the body, and then we basically keep our fingers crossed and hope that those organs can then heal up. What has not existed and what we've really needed is some drug or some other way of breaking down the amyloid protein that's in those organs already, because unfortunately that's really what people feel, and that's what's life-threatening in this disorder, meaning that the cells are in the bone marrow, protein's in the blood, amyloid protein is in the organs. When we do successful chemotherapy, stem cell transplant, whatever we're doing, we may kill off 99.999% of those bad plasma cells. That light chain protein drops down to normal levels, and so for all intents and purposes, we hematologists, oncologists are patting ourselves on the back because chemotherapy has worked beautifully, but the patient still feels awful and can still even pass away from the disorder, and because the organs are still beaten up. And that's because those drugs that we use to kill plasma cells do nothing to clear out that amyloid protein that's already stuck in the heart, that's stuck in the kidneys, that's stuck in the nerves, stuck in the different organs. And so what happens currently is that we suppress those bad proteins as best we can in the blood. Those organs can then start to heal up, but we know that that process can take many months, if not years. And so often when I see patients in clinic, I tell them that I hope that they'll start to feel better, but in reality, we typically don't see meaningful organ improvement in amyloidosis for at least 6 months after starting therapy. And that's very different from multiple myeloma, where if somebody comes in with, let's say, high blood calcium levels, you can fix that in 24 hours. And amyloidosis, that protein is stuck in the organs, and basically it just takes the body a long time to break down that abnormal protein that's already stuck there. And so that brings me to the really exciting new developments which are unique to amyloidosis, which is new drugs that are directed at basically sticking to that amyloid protein that's stuck in the different organs already and helping to break it down. So basically helping the organs to recover more quickly. And so there was one drug that we had a couple of years ago called NEOD-001, NEOD-001, and that was a drug that was in a couple of clinical studies a few years ago. Those studies unfortunately didn't pan out in the sense that the drug was not shown to be effective, but long story short is that there's another trial which is opening soon looking at NEOD-001 in patients with severe cardiac or heart amyloidosis, and that one will hopefully show that the drug has a benefit for healing up amyloidosis in the heart for those patients. And then the other study, which is ongoing now, looks at this drug called CAEL-101, so CAEL-101, and that's a drug that is being looked at in randomized clinical trials for patients with newly diagnosed amyloidosis of the heart. And all those patients get standard chemotherapy, and then a certain percentage of patients are also randomized to receive the CAEL-101 drug. Basically to ask the question, okay, for patients getting standard chemotherapy, so medicines that kill off those bad plasma cells, will this CAEL medication also help to break down some of the amyloid that's in the heart and help the heart to heal up faster than it would otherwise? So super exciting in the sense that, we've never had drugs that really help to break down that amyloid in the organs that's there already. That's really what we need because that's what gets people with this condition. And so hopefully these trials will show that there's a benefit to using that medication. So that's a really long way of saying that that's one thing that I'm excited about.
No, that's okay. Oh, it is. Okay. Interesting.
It is. And then the other study that I'll mention really quick.
Oh,
sorry, you go.
What target does that go after?
Yep, it is. So it goes after amyloid protein. It's basically that when the amyloid protein is formed in different organs, it has a specific protein sequence, and that's targeted by the antibody. It's designed to basically stick to amyloid. So I almost think of this like a laser guided smart bomb in the sense that the drug goes in, it sticks to amyloidosis that's in the heart, and it basically immune cells are able to look for that target and basically chew up the amyloidosis, we think. Cells called macrophages. it's really cool technology, and I say that as somebody who had we have the trials open, but I had nothing to do with the drug development. It's really neat stuff.
Wow, wonderful. Okay, I cut you off. You were going to mention something else too.
That's okay. And then I was going to mention, one other study, which is also really exciting, and this is one called the SAVE study. So that stands for Screening to Improve Survival in AL Amyloidosis. And this is one that we're participating in, who's led by my good friend and colleague, Dr. Ray Comenzo, up at Tufts Medical Center in Boston. And the idea behind this is that, back to your question about smoldering myeloma earlier, one of the keys to fixing amyloidosis basically is diagnosing it early. You can imagine that when that light chain protein is in the blood, it deposits in different organs over time, and it may only show up in patients when they become very symptomatic, and that's usually when the organs are heavily involved already. If we could get at this in an earlier phase before those organs are so significantly involved, then that would be even better, basically get it early. And so this is a study led by Dr. Comenzo, in which we're looking at patients who have lambda light chain MGUS, so monoclonal gammopathy of uncertain significance, or smoldering myeloma. So these are patients that have that protein that's in the blood, but they have no evidence of damage to any organs from that protein or the cells. And it's basically looking at the sequence of that protein to determine if we can predict who's more likely to develop amyloidosis, with the idea that we can do closer surveillance or even interventions early. And this is just based on what I said earlier about how protein sequences likely play a critical role in this condition, in the sense that, again, some patients can have really high levels of that lambda light chain protein and never develop amyloidosis, and then there are others who have really low levels of that lambda light chain protein, but it's perfectly structured to form that amyloid protein in the different organs, and it therefore goes ahead and does it. This study is really looking to basically sort that out at a scientific level that we can then use in patients to say, okay, does Mr. Thompson have smoldering myeloma with a lambda light chain sequence that's likely to form amyloidosis, in which case we need to watch closely or even think about intervening sooner, or does Mr. Thompson have a light chain sequence that's not likely to form amyloidosis, so we still need to be vigilant, but at least we don't have to worry about that condition. So really exciting stuff, basically looking at early diagnosis with an eye toward interventions and doing things about it before it becomes such a severe problem. So very exciting.
Yeah, really. That is very exciting. And is lambda type of disease just more likely to develop into light chain amyloidosis than the kappa?
It is. So it's both kappa and lambda can form amyloidosis, but it's about 2 to 1, meaning lambda about twice as more commonly causes amyloidosis as opposed to kappa. And a lot of that, again, just has to do with the structure of that lambda light chain protein versus the structure of the kappa light chain protein. Lambda light chain is just more likely to have the structure so that it can form amyloidosis in tissues, but really either can do it.
Oh, wow. Okay. I did not know that. I'm learning all sorts of new things in this show. And I think we will share that as a clinical trial because that is really important for patients to participate in. Yeah, that's really important. Super important for amyloidosis patients to learn from those types of studies. So this is something that I think all patients should know what type of myeloma they have. I mean, at the very basic, you have kappa or lambda light chains typically. And then you can have heavy chains, which are like IgG, IgA, IgM, and things like that too. So if you don't know the kind of myeloma you have or the kind of disease that you have, ask your doctor or your nurse. And just so you know that, that's something that we gather in HealthTree because it is important to see these connections between like kappa versus lambda. Like then you get to be able to, what you're trying to do is treat patients as individuals and not just generically anymore.
That's right. I couldn't agree more.
Yeah. Are there any other studies that are open for amyloidosis patients or light chain amyloidosis patients?
There's
those
smaller
the key ones.
Those are the key ones at this point.
Yeah. Okay. Great. Well, I want to leave some time for caller questions. So if you have a question for Dr. Tuchman, you can call 347-637-2631 and press 1 on your keypad. And we will go ahead with our caller question at 369-6595. Go ahead with your question.
Hi, I've really enjoyed the show so far. I did have a question. You had mentioned earlier that some of the side effects, like kidney damage and heart problems, can be reversed. Can patients actually gain back full organ function if we catch it early?
Yes, for sure. There's probably always a little bit of amyloid. Oh, I'm sorry, you go.
But how about if it's caught late?
It really depends on the type of injury, and most organs, if there's very significant involvement, then most often the organs won't completely recover to normal, but they can, and even beyond that, even if the organ doesn't completely recover to normal, meaning we do our testing and we still see evidence of problems related to amyloidosis, nonetheless, a patient can still feel extremely well in the sense that the body learns to work its way around problems, and so symptoms can entirely resolve even if the organ remains a little bit impaired. But in general, if it's early involvement, meaning low-grade organ involvement, then a lot of times that can resolve entirely, whereas once the organs are more severely impaired, then complete resolution of that is a little bit less likely, but still a lot of patients feel better, which is a great reason to still be hopeful.
Okay, great. Thank you for your question, and thank you for your answer. I guess I will ask you just a final question in terms of just finishing up. If a patient is listening and is diagnosed with AL amyloidosis, what do you suggest as the steps that they should take to get properly cared for? And then how do they work? If they're in a remote facility, how do they work with an expert in conjunction with maybe a local doctor?
So a lot of times, that can sometimes be tricky. Especially in the age of virtual medicine, which COVID has pushed us into, it's made things a little bit easier. And so at least within individual states, we have increased capacity to do virtual visits, meaning video visits. And it's always better for us to see a patient in person, but doing things from via video for patients who are truly too far away to make it to our center, that's an option. And then, one big thing that I'd say is just encouraging your local physician to reach out for help, recognizing that, most physicians are smart people and they may be very good at what they do, but amyloidosis is extremely rare, and even multiple myeloma is to some degree, but amyloidosis even more so. And so I think it's completely fair for amyloidosis patients to ask your physician, how much of this have you seen? How comfortable do you feel with this, with managing my condition? And do you think that we need to get help? And if so, what's the best way to do that? It really depends on where they are in the country, what the closest centers are, that sort of thing. But I think the first step is really getting a feeling for how comfortable your physician is with managing the condition.
Yeah, so it's time to ask your doctor lots of questions, I think. And then find a specialist who can, and when you work with myeloma specialists, we always encourage patients to especially meet with a myeloma specialist to consult with decision-making, essentially, when they're newly diagnosed, and then at each relapse. Is there a greater frequency that you suggest patients talk to an amyloidosis expert, or is it kind of similar that, and does amyloidosis, well, if you have it, you just continually have it. It's not like myeloma where it relapses, or is it like that?
It's very similar. So a little bit different. It's similar from the perspective of the plasma cells. So much like in multiple myeloma, we kill off a whole lot of the cells. They stay down for a while, but they like to come back at some point later. Amyloidosis is the same. So same issue with the cells growing, rising light chain or M-spike protein in the blood, that sort of thing. But the thing that's a little bit different in amyloidosis is that the organ damage can remain. So even, I have some patients that we treated 10 years ago for amyloidosis, and their amyloidosis is in remission, meaning that the light chains in the blood are totally normal. The bone marrow biopsy is totally normal. I don't see any evidence of those abnormal cells, but they still have the organ impairment from the condition. And so sometimes that's more long-lasting than the actual extent of the light chain protein in the blood. But in terms of how to monitor it, it's a lot of the same strategy that we use for patients with multiple myeloma, meaning that when things are busier, if the condition's coming back, if we're having trouble with increasing clinical symptoms, toxicity, that sort of thing, then patients may have more contact with us as amyloidosis experts, whereas if they're in remission and doing great, then we can probably spread that out. And so much like everything else in multiple myeloma, it's really sort of a waxing and waning course, sometimes more intensive, sometimes less so.
Okay. Well, this has been so valuable today. It's really incredible to talk to experts in the disease because it's so nuanced. It's just incredible. So, Dr. Tuchman, thank you so much. Yeah, I know, right? So you need to have the best people possible on your team if you have AL amyloidosis, which we suggest going to a specialist every time. It's so important for your care. Dr. Tuchman, thank you so much for joining us today.
Thanks for having me. This is
for
great.
Sharing your experience. Yeah, it's so important to. I was talking to another doctor who works on AL amyloidosis a little bit, and she was just saying, I feel like it's kind of like the sometimes neglected family member that we need to make sure we take special care for these patients. And she had a special place in her heart for them. I can tell you do too.
I do, for sure.
Yeah, well, thank you so much. And we wish you all the best with your continued work. We will share your studies that are open so patients are aware of what's available to them. And you can find out a lot more, especially with that precursor condition study. So just thank you so much.
Sounds great. Thanks so much for having me.
Yes. And to our listeners, thank you so much for listening to Myeloma Crowd Radio. We invite you to join us next time to learn more about what's happening in myeloma research and what it means for you.
With the Lucky Land Slots, you can get lucky just about anywhere.
This is your captain speaking. We've got clear runway and the weather's fine, but we're just going to circle up here a while and get lucky. No, nothing like that. It's just these cash prizes add up quick. So I suggest you sit back, keep your tray table upright, and start getting lucky.
Play for free at LuckyLandSlots.com. Are you feeling lucky? No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.